Thank you, Dr. Mehta, for this introduction. Here today I'm going to review the current AASM recommendation for scoring respiratory events in pediatric patient and the gold standard and alternative respiratory channels for scoring respiratory events, and a few interesting or difficult cases we can say from the ISR. So score a respiratory event as an apnea when all the following criteria are met. So drop in the peak signal from 90 equal or more than 90% of the pre-event baseline using an oronasal thermal center diagnostic study. When you do the PAP study, it's from the pipe flow, device flow, or an alternative apnea centers diagnostic study. The duration of the greater than 90% of reduction of the signal sensor lasts at least the minimum duration as specified by obstructive, mixed or central apnea duration criteria. The event meets respiratory effort criteria for obstructive, central or mixed apnea, then you score an apnea in children. So obstructive apnea. Score an obstructive apnea if it meets apnea criteria for at least the duration of 2 missed breaths and is associated with presence of respiratory effort throughout the entire period of absent airflow. Identification of an apnea does not require a minimum desaturation criteria. And if a portion of a respiratory event that would otherwise meet criteria for hypopnea meets criteria for apnea, including 2 breaths minimum, the entire event should be scored as an apnea. So now gold standard and alternative apnea sensors. It's for the scoring apnea, the gold standard is thermal flow, and alternatively, because it's very difficult to get the signals in kids, so alternative sensors are very helpful. So alternatively, we can use nasal pressure flow and rib sum or rib flow and end-tidal PCO2. So here we can see very nice explanation for the obstructive apnea. You can see the flattening of the oronasal airflow sensor and the oronasal sensor. Here you can see some respiratory effort. So, and it meets the criteria. Here I have chosen few records, like not in one ISR 1 month, so several months I can use. So here every record they say how much is the 2 missed breath take. So here it meets that criteria. It's more than 2 breaths. You see the absence respiratory flow, like thermal flow, as well as the nasal flow. So this is an obstructive apnea. So here, and in the first slide, you can see you don't need a desaturation here to score an apnea. So here the same thing, but you have the desaturation, which we don't need to score obstructive apnea, but you can get desaturation during obstructive apnea as well. Here one example that it meets the criteria to score as this part is meet the criteria for the apnea, but here there are some ventilations here in the thermal channel, so it's hypopnea, but we have to score entire event as an apnea. So central apnea. Score an apnea as in central apnea if meets the apnea criteria, is associated with absent inspiratory effort throughout the entire duration of the event, and at least you have to have one of the following. It has to be more than 20 seconds, or the event lasts at least the duration of 2 breaths during baseline breathing, and it associated with an arousal or 3 or greater than 3% of oxygen desaturation. The event lasts at least the duration of 2 breaths during the baseline breathing, and it's associated with the decrease in heart rate to less than 50 beats per minute for at least 5 seconds, or less than 60 beats per minute for 15 seconds only in infant under 1 year, which we don't do in our labs. So this is an example of central apnea. You can see that here thermal flow is less than more than 90% reduction, and here nasal flow is more than 30% reduction. But here most of us usually think this is an effort, but it's not an effort. This is oscillations from the ECG channel. So we have to be very careful and thinking this is an effort. So this is not an effort. So this is a central apnea. And scoring mixed apnea. Score an apnea as mixed if it meets apnea criteria for at least the duration of 2 breaths during the baseline breathing, and it associated with absent respiratory effort during one portion of the event and the presence of inspiratory effort in another portion, regardless of which portion comes first. There is not sufficient evidence to support a specific duration of the central and obstructive component of a mixed apnea. The specific duration of these components are not recommended. So here is one of the mixed apnea. You can see the thermal channel fully flattened as well as the nasal channel.
Just a minute. Okay.
So you see for more than 2 breath duration there is no effort, you see. So it meets the criteria. The first part meets the criteria for an central apnea, and then you see slowly you see the respiratory effort. So it gains as a paradoxical. Usually it's like that in mixed apnea. So this is qualified as a mixed apnea. Okay. Scoring of hypopnea. Score a respiratory event as a hypopnea if all of the following criteria. Sorry, we have to admit someone here. Score a respiratory event as a hypopnea if all of the following criteria are met. The peak signal dropped by 30 or greater than 30%. The duration lasts for more than 2 breaths. There is a 3% oxygen desaturation, or the event is associated with an arousal.
Okay.
So here gold standard and alternative hypopnea sensors. So we usually use the gold standard sensor for the hypopnea is nasal pressure sensor, but alternatively we can use the thermal airflow or rib flow or dual thoracoabdominal respiratory belts. So here is an event in ISR gold standard panel. They scored this as a hypopnea, and I just want to know anybody knows why they scored this as a hypopnea here.
You can check the chats if anyone is. You can ask everyone.
So, anybody can say why this is hypopnea here?
There's a arousal, there's a decider attached to it.
Okay. But you don't see any effort here?
Maybe there's artifact or what?
Actually, the gold standard panel, they say here in the airflow sensor, there is some ventilation still there. So it's not qualified as a central apnea. So this is an hypopnea.
Tell me again
Okay.
why you call it.
Because there is no signal respiratory effort, but they say the thermal airflow sensor, there is some ventilation. See, it's not a 90% reduction here, so ventilation is there. So we cannot say that as a central apnea, because for central apnea the criteria it has to have flat in or more than 90% of reduction. So when it doesn't have that, so they qualify
so you
this.
can get the effort sense from the thermistor and cannula too. Usually we
The
look at the
cannula
breast
is
for
flat. That is correct. The cannula is flat, but the thermal it's not flat, or it's not 90% reduction here.
Okay.
So even though there is no respiratory effort, they call it as hypopnea, because it meets the criteria for the hypopnea. As you said, there is an arousal and then desaturation here.
It can be exam question. Those who are taking the exam, 5 of you are taking the exam, guys. It's important.
So there is arousal before the event and after the event, right?
Yeah, that is another thing. Like usually, I will come for that later, like before then arousal. But here it meets the criteria. There is an after arousal as well, right? So anyway, it's qualified for hypopnea. It's not moving. Okay, to say this, like it's more than less than 90% reduction, they do a baseline from the healthy breath here. They draw a baseline. When you see, it's definitely, there's no 90% reduction here in the thermal flow. So this is qualified as a hypopnea. So here is another example. So here, like when you see, there's a ventilation in thermal flow, but there is a reduction. So when you go and see, draw a baseline here for this event, it's when you see there is a 30% reduction here. See here, 30% reduction for at least for the 2 breath, and there's an arousal. So it's scored at hypopnea. So this channel is, because it has some artifact, you can see the movement here. That's what it was pretty difficult to see, say whether there is a 30% reduction or not. But it's there are 30% reduction here. So this is another easy hypopnea. There are 2 breath. There's a reduction here as well as in thermal flow. So there's an arousal. So this is hypopnea. And one more here the arousal is as soon as the reduction, you get the arousal. But there's a question, how is there any minimum amount that how much away from the arousal the event is away from the arousal. But in a scoring manual, there is no definite answer for that. But the gold standard panel, they think there is at least 5 to 6 seconds from the arousal, they can still score that as an event. So here they, just to see from the baseline, they draw, and it is the nasal flow is 30% reduction here, more than 30%. So this is an hypopnea. And another thing is a long, very long hypopnea. So we wonder whether the kids used to have, or whether we can score this as a hypopnea this long. Yeah, we can score here in kids. There's long hypopnea as well. It's more than 30 seconds here. So still we score this event as a hypopnea when it meets the criteria. And chain of hypopnea events here. See so many hypopneas. Of course, here's an obstructive apneas. Still, it's very common. We used to see in kids. We can score these things as a hypopnea. Some of us has doubt, like whether there has to be 2 healthy breath, or how many healthy breath we have to have in between. But here we can see whenever it meets the criteria, we can just score that as a hypopnea. And this is another thing that we used to see. So here are some central portion, and here some central portion, but it's not meeting the criteria. It's not, the duration is not enough, and here the duration is not 2 missed breath. So we have to score the whole thing as a hypopnea because it meets the criteria. There is a 3% desaturation here. And here, this is an obstructive event. No, this is a hypopnea. See, you can see there's a nasal flow, thermal flow, the ventilation is there, but here it's reduction. Here you see the respiratory effort. And there's a question here whether we can score this as a hypopnea or not. There's a desaturation, but the desaturation is a little bit further from the event, the flow reduction. So still whether we can score it or not. Actually, even here again there is no definitive answer from scoring manual, but gold standard panel, they think if it is less than 4 to 5 seconds, then it is associated with this event. If it is not, then it's suspicious, they think. So score this respiratory event, whether we can score this as an event. If so, what kind of event this is. Anybody want to answer?
From Zoom as well.
Yeah, from Zoom as well, you can unmute and answer. So
mixed event.
To qualify for the mixed event, it has to have the central apnea portion here. But if you see the, one second, it's until this there is thermal flow, there is a signal. So from here to here, it's not meeting the central apnea portion. It's very short to be a central apnea. So we cannot say this as a mixed apnea. To say obstructive, again, it's not meeting the criteria. It's not enough. The duration is not enough. It's not to score as, and its reduction is not 90%. It's going up again. So only thing, it can be hypopnea, but to score an hypopnea here, the desaturation is more than 5 seconds away. So this is suspicious. So in the gold standard panel, they didn't score this as an event. And here are some. This is actually, I got it from an adult, but it can, for the pediatric also we can use. So they say here in this picture, there's one event and 2 desaturations. They say from 96 to 93, 1 desaturation, and other one is 96 to 92. There are 2. So whether we can score this as one event, or we can score this one event and desat from 96 to first 93, or score one event and ignore the 1% resaturation here. See, 93 and then it goes to 94. We just ignore this resaturation and score 96 to 92. Would this change if the change the scoring if the second desaturation went from 94 to 91? That means there is 3% desaturation, right? So answer for this is typically the length of the desaturation will match the length of the decrease in flow signal, though the oximeter will always be delayed because of the plant gain, like from the when lungs to the things goes to the fingertip, it takes some time. So there will be a slight delay for the desaturation, but usually typically the length, they match the length of the desaturation will match the length of the decrease in flow. So if we see that from 96 to 93, we can score this as only one event. And here 2 events and 2 desaturation separated by 1% resaturation. So here you see at 96 to 93 and then resaturated to 94. Again desaturation, 3% desaturation to 91. So score as 2 separate event with 2 separate desat, or Score the first event and consider the DSET as one DSET from 96 to 91. Ignore the second event. Would it make any difference if the second event went from 90 to 94 percentage to 90 percentage lower? Would it make a difference if the second event was obstructive or central? So here to check for the last question to see whether obstructive or central, the respiratory flow, we have to see the flow. So here we see some movement, so it's definitely not central. And see the obstructive, again the thermal flow is not less than 90%, so it's hypopnea. So if the flow signal return to baseline, there are two events. So it's depend on here the signals. If it is with the baseline, then there are two events with 2 DSAT. We can say that. So it's and 2% resaturation rule only applies if baseline breathing cannot be determined easily. If the baseline, if we don't, between the two events, the baseline is not clear, then they, when to end the event, they see if there is 2% resaturation. So here, if it is clear with it's returning to the baseline, then it's two different events. And here two events and only one desaturation events are distinct. See here some flow, again the decrease in airflow, here it's gaining again and then decrease here. But the desaturation from 96 to 92 here, 91, 90, so 1. Score as two separate events and one desat, or score both events as one event. Ignore the breath in between with one desat. Score the first event, attribute that to the desat, and ignore the second. Would it make a difference if either of the two events were obstructive or central? So they say the answer is depend, because the picture is not clear. So this is uncommon if there is a significant return to the baseline airflow, because there is usually a resaturation. If there is sustained return to the baseline more than 2 breaths, then there are 2 events. But again, they say it's undefined in the scoring manual.
Just a minute. Okay.
So the fourth question, DSAT before the event start. So here you see it looks like a healthy breathing, and then if there's a decrease in reduction in the flow, but this is 90% from 96% from it's going down to the 90%. So whether we can score this as an event, if so the desaturation is from 96 or 90 up to 90, or we start later than that. So they say typically the desaturation and the reduction matches, but sometimes here the picture is not clear. Sometimes you see the reduction but not 30% to count. There will be some kind of reduction will be there when the desaturation start. So typically you will see some decrease in the flow signal even if it does not yet meet the 30% cutoff. If, however, the entire desaturation occurs before the event start, you cannot score it unless there is an arousal. Specified real-world examples are needed them to provide more detail. So if the desaturation start before the reduction of the airflow, you have to have an arousal here, so to qualify as a hypopnea here. And this is the example that we have seen before. There's a central part of central events, portion of central events, and then hypopnea, and then normal breathing, again hypopnea, again the central. but the central is not enough to score as a central events. So whether we can score the whole the central events with the hypopnea part or only the central part. Actually, we cannot score the hypopnea part, including the hypopnea part, and score it as a central. We have to have the central portion meet the criteria. Then only we can score this as a central event. That's what they say here. This is another scenario which we usually see in our records as well. Say there's mini central portions divided by some kind of fluctuation here. So whether to score this as a central or ignore and go, or we score this as a hypopnea. If it meets the criteria to score as an hypopnea, we need to score the whole event as hypopnea. So here, Romika, the question that you asked, there's an arousal. After the arousal, there is respiratory event after the arousal. When it meets the criteria, according to ISR, they score this as an event. But it's depend on the clinic. Some clinic, they don't score this as an event. Some clinic, they score this as an event. It can be, some people, they think it's a physiological response, so they don't score this as an event. But when you see the chain of central apnea, post-arousal apneas, then it's some pathological. We have to score this as an event here. When scoring an oxygen desaturation, what is the maximum length of time between successive O2 drops that allow the drop to be included as part of the desaturation? So this is the one which we came across before, like the event ends and then the desaturation, how long the minimum duration. So we typically only score desaturation in conjunction with the respiratory events. So would begin the desaturation approximately when the flow signal decreases. Keep in mind the plant gain concept related to the loop gain phenomenon. However, they say there's no definitive information about this in the scoring manual, but still.
Is there anyone saying something on Zoom? Is it possible to watch the morning sessions, please? Okay, never mind. Okay, wait.
Sorry about that. Here, special circumstance for scoring respiratory events. Scoring respiratory events during the positive airway pressure titration using the backup rate. So when we can score central event during the, when we use the backup rate, so for that flow has to be flat, and then the chest and the abdominal, they have all three has to be flat. During that time, there you have to have the induced breath has to be there. Device triggered breath has to be here. In this case, see normal, and in here it's device triggered breath comes. So in this situation, we can score this as a central apnea. Okay, any questions? Actually, any questions?
Can I stop sharing?
Mm-hmm.
You done?
Yeah.
Did doctors let us wait? So we have to do the evaluation form for everything?
Yes.
You done?
If anybody has any question, you guys can ask Kunthavai.
I have a question if nobody else does.
Yeah.
There was a comment made earlier about scoring pediatric records compared to adult records in terms of time and effort. I'm just curious from your perspective, how would you measure that? Or do you think there is a significant difference?
Obviously, because of the signal, actually, especially the pediatric signals are not clear as the adult, so it's really time consuming than the adult records.
Would you say double, triple? Do you have a sense on the average? How much
Again,
longer?
depend, like, if the adult with a very severe apnea, of course, that consume more time. And compared to the adult in pediatric, there is not that much even, so it's depends on the records and the severity. And
Fair enough. Yeah, for sure. I'm curious as well. Can you hear me, hopefully?
yeah, we can hear.
Okay. Just about how you developed your experience and expertise with the pediatric records. Do you have recommendations for the techs and scorers out there to how to get more comfortable with pediatrics?
Actually, you can always go and see the already scored pediatric records, like, again and again. Then you will get some ideas how it's scored and what are the comments made for those things.
IHF requirement is first 20 records they should score by looking at the other records already scored. Then independently they score again. Then that one has to be reviewed by the technical director and the medical director. So only if the sleep specialist is comfortable, only then we allow them to do the pediatric scoring. And if you or Dr. Bola are comfortable, then we let them. That's the process we followed with Grant, Kunthavai, and Menla. So whenever we need, we start the process 3 months or 6 months ahead, and we document that. And it's a requirement which is checked during when we are inspected. They say what was the training given, we have to provide the proof at that time.
Thank you. Yeah, that's good to know. I always feel though the official requirements are always the minimum, and our scorers have so much experience, record after record. It's unparalleled. So thanks to all of our scorers.
It was easy for them because for 10 years, more than 10 years, they did adult scoring. Then Manuel was scoring in cricket also. So it was a process. Slowly and slowly we developed in other kids, so the other technologists who want to become pediatric scorer. So whenever we are in the need, we start planning 3 months or 6 months ahead, so that they are ready to do the job.
There is one question from Miriam.
Miriam asked, techniques do you use to help differentiate stage 2 to 2 and 3?
How you want to answer?
Yeah, it's slow waves. In stage 3, you see for the slow waves more than 20%, and in 2 you see the spindles or K complex.
So there's a reference line helps a lot. At least in 30-second epoch, 6 of the data should be there touching. 6 or more in 30 seconds is the short test. It's a stage 3, and in K easy, one spindle or one K complex is enough to score to stage 2. And 50% of the night is in stage 2. It's the delta, sometimes used to confuse, but later on ISR records have shown delta must touch the reference line. Before 2008,
Touch or more than
even if they don't touch, we were able to score on our judgment. But now they are very strict. Deltas must touch the reference line. And although in old people delta are not touching, before we used to say in younger people delta is amplitude is higher because the skin is not thick enough. But in adults also they put the rule that 6 delta or more than 6 must touch the reference line, and then we can say it's stage 3.
I hope
I got.
the answer.
I think.
Can I ask a question?
Sure, go ahead.
Sure.
And In ISR, they are working in some intelligence, artificial intelligence for making some software for scoring. I want to know your opinion or how much progress they make to make such a software.
I am playing for last 10 years. None of them is perfect. So in Ontario, according to IHF and CPSO, we are not allowed to use auto scoring in any lab. It's not allowed. And inspectors during IHF, they are very furious if they do that. We have to do manual scoring, and so as a technical director, I do compare what's available in the market, and at the most, I can say 60% correct. But it takes more time to use the auto scoring than you start doing corrections. They cannot replace the real scorer. So it's we can depend on DSAT signals. That's because machine to machine, they are quite accurate. And stage and the other one, respiratory events, as Kunthavai and Menlo has showed there, it's impossible that autos algorithm can do a good job there. Does that satisfy your answer? If someday you come and I'll show you. So there's nothing can be replaced experience scorer.
I hope.
This is being done in Calgary or Vancouver or Montreal because there's no rules, no regulation. But in Ontario, we have very good senior doctors are on IHF, and they know the value of the personal scoring, and they are enforcing it very carefully. IHF and similarly senior tech who come for inspections, they are very good in scoring, and they do check, and it takes them only 5 seconds to know is it auto scored or not. It's easy, very easy to know. Please make sure that nobody touches auto score because our license can be at risk. And we never did, and we don't want it to be done. Thank you.
Thank you.
So, Dr. Mehta, are we done with Kunthavai? Are you done?
Yes, Inda.